Hello everyone. Welcome to the second psychoeducation session from the Neurodivergent Brain Body Clinic. I'm Anna Watson, who I'm sure most of you or all of you would have met in our initial appointment. And today we're going to be talking about the crossover with mental health, neurodivergence, and chronic physical health conditions. As we know, it's all a very interlinked web. So thank you so much for making it, especially amid all the admin confusion. And here's a general overline of today what we're going to talk about. Neurodivergence and common comorbidities, such as mental health conditions as well. Chronic health and the impact mental health has, and vice versa. Energy, motivation, and managing mental health alongside neurodivergence or hypermobility, EDS, etc. And then we'll also talk about other topics that we're hoping to do more research into and eventually have more of these kind of psychoeducation opportunities. Okay, so to get started, a bit of background about neurodivergence and common comorbidities or co-occurring conditions. A massive thanks to Ellie for putting together a lot of these stats for us. So as a lot of you know, or probably experience as well, ASC or ADHD rarely comes alone, and here we have some examples of common comorbidities that we experience alongside them, anxiety and OCD being pretty big contenders, and usually I'd say quite inherent into one's experience of neurodivergence. Then along with chronic pain, hypermobility, PMDD, that stands for premenstrual dysphoric disorder, other hormonal conditions, and the overlap is immense and really hard to unpick sometimes when something might be anxiety based or autism based, and sometimes it's a mix of both. And at the bottom, research in this area aids inclusive interventions and support for an underserved patient population. I believe that a lot of the time in treatment, at least, we look at singular mental health symptoms separately from, say, someone's neurodivergent profile, and maybe that leads to things like CBT being offered with the sort of low understanding of neurodivergence, and maybe it's not as effective as when we look at things all together. So firstly, a little more insight into anxiety and the connection with neurodivergence. Under half of all autistic people experience anxiety at some point in their lives. This is from a 2020 study, and I'm sure that this is probably underestimating it as well. 40% to 42% of autistic people report lifetime prevalence of anxiety disorder alongside ASC or ADHD. I think there's so many different reasons for this that come from both maybe the genetic and neurological basis that anxiety and ADHD or ASC can share, but also, I guess, the result of living in a society that's not necessarily built for neurodivergent people, and there's a lot of pressure, and therefore anxiety is going to be more likely. And as the second point says, this can lead to a reduction in social functioning, increased sensitivity to senses, difficulty in adjusting to change, which are all things we know neurodivergent individuals find hard anyway. So when there is heightened stress or anxiety, it can cause a bit of a snowball effect. The 2019 study here, we've put the names. If anyone's research inclined, you can go and have a look at these studies, but otherwise you don't need to worry about them. But there's a 25% comorbidity rate between ADHD and anxiety, although I would say from within the clinic, personally, it's a lot higher in what we observe, I think. And sometimes I think in assessment, one will get maybe dismissed or ignored because another's recognized, and it will get attributed to just neurodivergence or just anxiety when there's a lot of interplay between them. Another anxiety disorder, OCD, but it's isolated here because I'd say there is a really marked prevalence, especially with autism and OCD. Here's a really good Venn diagram. I hope you can read that on the right. If not, I'll go a bit into it. And it can look very similar, I think, on the surface, that someone might appear quite rigid and stuck to their ways, but actually there's very different driving factors between, say, autism and routines and preferences there compared to compulsive elements where there's maybe more of a fear and anxiety element rather than just a comfort element from it. So yeah, as the box has here, recurrent thoughts triggering a state of anxiousness seen in OCD, that compulsions relieve the anxiety and are performed in response to these thoughts. So given, yeah, with the anxiety disorder aspect of it, they can overlap a lot in that someone's autistic preferences might also then feed into compulsions as well. But it can be hard with assessing these, and it must, I think, be kept in mind if treating OCD that actually, you know, maybe there's an element of routine and sameness that's, if someone's neurodivergent as well, that is important. Yeah, I think it clinically, people who are less, I suppose, aware of the way autism and OCD can present complexly might look at autistic behaviors like stimming and the examples there of watching videos on repeat or a specific order for doing things. They might misattribute that to be a compulsive, and I'd say then it's sort of harmful asking someone to change that or stop that. So again, just another example of why I think healthcare providers should really understand the differences and links between these things before people get told to do something that's harmful for them. And at the bottom, this is a study from Dr. Jess Eccles, who, as we know, is ahead of a lot of the research going on in this field that shows OCD is a 13 times increased probability alongside an ASC autism diagnosis. And I think that just shows even more the overlap. And on the right, with the Venn diagram in the middle, showing that both of them often show repetitive behaviors, speech, urges, inflexibility with routines, sensitivity to the environment, and fixed interests, but the reasoning behind them will be different. But yeah, we can ask some more questions about that in a bit if anyone has any. Next, neurodivergence alongside psychotic disorders. And here's some more studies if people are interested in the prevalence. And more so than with ADHD, there is a sort of scientific connection that's been noticed between autism and psychosis. Again, part of this might be attributed to, again, the greater level of stress and just daily living in a society as an autistic person, increasing levels of stress, which then increases likelihood of sort of psychotic experiences if you are already predisposed to them. Also, additional comorbid psychotic disorders, including bipolar disorder and schizophrenia. Something as well that I think I've noticed a lot clinically is people who are diagnosed with BPD or EUPD that later turns out to be, say, just late diagnosed autism or atypical neurodivergence in some way. Often, well, BPDs comes with some of these psychotic experiences. And I think, again, it's an example of things being misattributed, where maybe it is an autistic related experience instead. But yeah, at the bottom, we do have some research on the ADHD prevalence with psychosis. 3 times more likely to develop schizophrenia, with 10% developing psychotic symptoms. And again, I think a huge player in that with ADHD is the element of stress as well. Maybe with ADHD, there's much higher impulsivity and likelihood to be, I don't know, having unhealthy sleep patterns or using drugs that maybe make psychotic experiences a bit more likely to occur. But still not the most common comorbidity. Does anyone have any questions about those bits so far? We have one here from Grace. Could the psychotic experiences be linked to dissociative disorders as they are? Yeah, often mistaken for psychosis. Yeah, that's a good point. And another thing I didn't think of that ties into this is trauma, I think, as well, results in a lot of those experiences that, yeah, on the first look of it, someone might just pin it down to a psychotic disorder when actually, yeah, maybe there's other elements like dissociative disorders or trauma involved. Yeah, does anyone else have a comorbidity related question? Cool. Next, looking at how chronic health conditions, mainly sort of physical like hypermobility, fibromyalgia, and mental health impact one another. So here looking at rates of chronic pain, frequent comorbid conditions in the neurodivergent community include hypermobility, as we all know and have been assessed for here. IBS, migraines, fatigue, poor sleep, brain fog are some examples, but I think the thing with connective tissue disorders like hypermobility is that it really does impact everything. So if I put a list of chronic pain that's commonly experienced for neurodivergent people, it would just be everywhere in the body, just in different amounts. And yeah, the second point kind of encourages the point of the dysfunction of the autonomic nervous system, which really does run throughout all of us. So research by, again, Dr. Eccles and people at BSMS has shown that the elevated prevalence of joint hypermobility, autonomic dysfunction, and musculoskeletal symptoms in neurodivergent individuals was, very related. And to sort of explain that in less long terms, is showing how, bendiness and that joint hypermobility is really linked to feelings of, say, dizziness that we see in POTS, sort of arthritis and fibromyalgia kind of experiences. And at the bottom, it shows that the number of hypermobile joints can mediate the relationship between neurodivergence and both dysautonomia, that's like the sort of heart and dizziness symptoms, and pain. So yeah, this research has been really important in the setup of this clinic, for example, to really show that by looking at our joints and tissue as a whole, it really does say a lot about the mental health and also neurodivergence and other physical health experiences. Future research and services are able to provide interventions and management for core symptoms. I think just our main goal is really trying to look at all of these factors as a whole, because then it's not just trying to put a band-aid on until the next time, So pain and autistic traits. This was a 2023 study that showed autistic traits have the highest correlations with widespread pain and dysautonomia. Highly significant association between autistic traits and fibromyalgia, which again comes up a lot in the clinic. Autonomic dysfunction, hypermobility was the mediator of the relationship between autistic traits and fibromyalgia. So really, I see all of this stuff and pain as a big interconnecting web, and it compounds. So if you have traits of autism along with hypermobility, it increases the likelihood to have these other things like fibromyalgia and autonomic symptoms as well. In 2022, this other study is showing, again, fibromyalgia and hypermobility and neurodivergence being related, and that there's a higher prevalence of autism and ADHD than the general population for those with fibromyalgia or hypermobility spectrum disorder. So then, looking at how having a chronic illness leads to mental health issues, there's a few studies that show benign joint hypermobility, which now we can call symptomatic joint hypermobility, if you will, has greater perceptions of fear, more intense fear, and higher probability of anxiety, depression, and manic disorders. And that was from 2014, showing that there's a greater connection there. Another one showing increased incidence of mood disorders, depression, fatigue, worsened sleep quality, and impaired quality of life in patients with hypermobile joints when compared to so-called healthy controls. And I think on the next slide, oh, never mind, I'll just talk about it. It makes sense that obviously quality of life, sleep quality, all of these things do lead as well to an increased level of depression and fatigue. So if you are just in more pain and have less energy, it's more likely that it's going to mount in mentally, I suppose. A little bit about PMDD, premenstrual dysphoric disorder, menopause, and mental health. It's pretty much 100% of people that come through the clinic that experience menstrual cycles or menopause have said that they've noticed their experiences are different to other women that maybe aren't neurodivergent, and that the hormone sensitivity or fluctuations are more noticeable, or things like pain, and also the incidence of things like endometriosis and PCOS, which I think the clinic would love to do some proper research into to see if it's also linked. Yeah, here with this stat of autistic women experience increased menopausal complaints and associated with high levels of depression. This is seen a lot in both ADHD and autism, and is basically what PMDD is about. This 92% of individuals that find the week before their period, a worsening of both, say, the brain fog and neurodivergent issues, but also greater anxiety, depression, and maybe trauma responses if that's relevant to them as well. And I think that's something that I certainly didn't hear about for years until learning about autism and neurodivergence, and probably should be shared more, especially with GPs. And I know even gynos and things have sometimes been really dismissive around these problems. So hopefully over the next year or so, we'll be able to pump out some more education and information to healthcare providers around this link. The physical and mental health interplay. As I said earlier, the treatment between them is almost completely separated in healthcare. And Dr. Jess Eccles has done a lot of work, both before the clinic even started, but this work really underpinned the argument to create it, really was proving that looking at the amount of hypermobile joints could also map the level of, say, depression or anxiety felt at or experienced at an older age, which is wild to imagine, even though, we talk a lot about how mind and body impact one another, but being able to really see how in the future someone's mental health might look just from their joints is something that, on the face of it, I wouldn't expect the research would show. So it really is all also important to look at together. In the blue part, referrals for neurodevelopmental assessment to the NDS, that's the Neurodevelopmental Service, frequently come from mental health services or include evidence of mental health symptoms. I'd say there's about a 70 to 80% incidence of people that are referred to the NDS that also have at least, say, an anxiety disorder diagnosis or a depressive disorder, and then more. And 2 years ago, we did an audit that showed for people with both ASC and ADHD, which is higher than we think, there's then an increased likelihood to have other mental health diagnoses as well. By appropriately considering how neurodivergence impacts mental health, this can better future clinical assessment approaches and healthcare by ensuring links are recognized and identified. Also, because I think a lot of people, by the time they get referred for, say, neurodevelopmental diagnosis, or neurodivergent diagnosis, I should say, they've already been through so much more trauma or adversity because of being neurodivergent and not diagnosed that could have been prevented, should it all be understood from an earlier age, and maybe have had years or decades of like depression-focused therapy when actually maybe it wasn't getting at the root of the cause of the depression as well, for example. So looking at why is there this disconnection and what we can do to address it. At the moment, I'd say a lot of the barriers to connecting mental and physical health include things here like medical dismissal, misogyny, and racism in, say, access pathways such as the GPs, or some of you as well in your initial assessment spoke about rheumatologists or physios who didn't believe in hypermobility or didn't believe in PMDD or hormonal things. And I think there's a lot of as well bias in medicine against people who are very well versed and I suppose well read in their condition, because it's read as, I don't know, maybe seeking something when actually, it's just the result of being ignored for years and having to do it all by yourself. You end up having to know everything and advocate, but I think more weight should be put to that when someone comes in and really, can explain how all of their experiences have been over the last few years, not to just go, oh, well, I've never seen it before, it doesn't exist. And so that's why with the reports that we send out, we try and make sure that the GPs also have a look at a number of resources that show the link between mental, physical health and neurodivergence, along with hypermobility. So at the moment, yeah, one of the biggest barriers is separate referral routes or specialist services. I'm sure a lot of you have individual experiences of this, where maybe you'll go for mental health support that probably maybe you wanted to be a bit more rounded, thinking in a neurodivergent sense, but also addressing anxiety and depression, because it's all sort of one glob. And really they go, oh, well, pick one symptom, here's 6 weeks of something, and then off you go, let us know if it gets worse, which really isn't the picture for neurodivergent people. You know, it's more of a, well, literal spectrum, I suppose. And I'd like to think that moving forward, there will be, at least say in ATS, where all the main assessment and treatment referrals go to, there's a checklist almost of, if someone's coming through and they think maybe they're neurodivergent, that they also then get considered for physical health screenings and mental health screenings, rather than it getting to a point to have to connect the dots. It should be done for people. And yeah, I think there's a lot of lack of clinical recognition or training in these links. And I think this clinic existing is one of the best ways we can combat that, by producing documents and resources to share, which has been good. And we've had a lot of interest from other people in SPFT who want to, learn more or be trained in hypermobile assessments. And since May, which is when we opened, the interest from other professionals has really risen. And I think it's quite interesting as well, hearing from people who've worked, say, in autism services for 10, 20 years, saying, oh, wow, I never realized how related it all is. And now I can really look for this in assessment. So it's definitely shifting, but it would be nice, obviously, to see it improve in terms of GPs and hospitals as well, where, it will be known without people having to explain for them. Before we move on to managing mental health alongside everything, do we have any questions about the bits we've talked about? So is there any way we can tell if a comorbid condition is caused by neurodivergence or not? I think that's a really hard one, and it goes back to the age-old debate of, is something caused or just correlated? And I'd say it's always more likely correlated. And for example, if you take someone with ADHD, it's not 100% set that they will also have, say, a depressive disorder or an anxiety disorder. But if you took a room of, say, 10 people with ADHD, you're more likely to have over half the room have at least one of them, but someone might not, kind of thing. And it's easier with some things than others. Like if we look at autism, perhaps it's easier to see when someone has a mood disorder, perhaps, than say OCD. And again, because of the similarities between a lot of the routine and sameness preferences in autism that are also kind of present in OCD, I think there's a lot of difficult overlaps to unpick. And I think what's harder as well is where there's not so much of an overlap and people don't think about the link. So for example, a lot of our autism referrals come from eating disorder services as well, where there's a really high precedence, especially for females with eating disorders and autism. And I think it's missed because a lot of the maybe control behaviors are put around eating disorders instead of looking at, oh, is this actually also neurodivergence? And maybe because it's an unexpected link, people don't search for it, even though I guess it's obvious when you know what you're looking for. Other questions says, fibromyalgia. Yeah, fibromyalgia is a condition that causes a lot of nerve pain, and again, it's related to the connective tissue stuff, and I think does have a very strong link with hypermobility. And I'd like to think some of the research we'll do can show those correlations, because there's definitely a high amount of people. But yes, I can send some more proper resources about that if you want to email the inbox at some point. Yes, in terms of paperwork, studies and slides, yeah, I'll send around the slides when I'm hoping that at the end of this and then the January session, all of these slides will be sent out along with a link to rewatch the videos, but the Q&A sections will be cut out for confidentiality. Yeah. Okay, onwards to managing mental health. So there are many ways that mental health and neurodivergence change the way we're able to manage our physical health symptoms. So yeah, firstly, looking at how does mental health impact our physical health? Difficulties with organization, memory, or planning can make it difficult to remember or keep to treatments, medication plans. So yeah, this can be as simple as remembering to get prescriptions on time, taking meds every day. Maybe that's a big issue if you have ADHD. As well, it can be quite common that, say, medication plans, if there's sensory issues as well, it can cause an extra layer of difficulty around it. Then as well, looking at mental health impact from anxiety and depression can disrupt important functions such as sleep, appetite, energy levels, which in turn impacts physical health symptoms. Yeah, a lot of what we're recommended to do by doctors, especially when a problem just starts, is, make sure you slept well and you eat enough and that you rest well. But if someone's never really rested because they have chronic fatigue or ongoing pain, or if mental health is really bad, that is very, cognitively taxing as well. It's going to be hard for your body to heal up if it's busy at war with the brain, technically. Thirdly, even access to health services requires a large cognitive demand. Yeah, and it's, as we all know, not very neurodivergent friendly. There's always a lot of paperwork and answering the same questions again, which is difficult and can be hard or traumatizing. And again, another argument to why it all needs to be joined up, because then there would just be one good history rather than having to walk from service to service explaining the same thing again and again. So yeah, other examples of why the current way that physical healthcare doesn't really cater to neurodivergence and mental health experiences as well. Often a lot of us are told, if you do exercise every week or do this or that and stick to it, it will be a good treatment. But routine setting and maintaining is really hard, especially if you've got ADHD. Or conversely, if you have a really good routine and strict routine with it and you're autistic, any changes to that might be much harder to sort of continue that routine than someone neurotypical, say. Available energy for routines, exercise such as physical therapy recommendations, or general routines might fluctuate, and therefore, again, we're told to treat one symptom, do this exercise or take this treatment for this amount of time in a steady steady rate, which we neurodivergents aren't always great at making sure that and if there's other sort of things like pain as well, you can't predict on one day how much energy you'll have on another. And I think both for you to know in yourself, but also healthcare providers need to know and plan for that when asking or when setting up a treatment plan, that actually maybe there needs to be a bit of leeway in time of day and frequency, or more support and reminders, for example. In-person appointments or surgeries could be daunting if communication is not clear, reasonable adjustments not made with neurodivergence in mind. Yeah, I've heard stories of people going for an appointment or a surgery and being told that, they would have adjustments that then when getting there, told, oh, we can't do that, we don't do that, when, physically it's possible. And yeah, I think it's getting a bit more normalized now that there's things like the alerts on people's health records. But again, not everyone maybe reads and takes notice of them straight away, even though they exist. So yeah, those are some barriers of why I guess neurodivergence and mental health can make it harder to manage physical health. But this influence works both ways, and studies showing high prevalence of stress, anxiety, and depression among patients with chronic disorders. So makes a lot of sense to me that if you've been living with a chronic pain or an ongoing condition and it's not been addressed or treated properly in the medical system, that does, it grinds down on you eventually, and it is going to make you more likely to feel depressed or anxious. And there's, yeah, so many factors that we do not have time to go into, honestly, into how chronic physical experiences can impact our mood. And some of the work we'll be doing with interoception and that one-to-one therapy that we're working on bringing out is looking at how, if you're so used to on sudden changes and symptoms starting in your body and pains that you can't always identify or work out, often it makes sense that there's going to be an anxiety response to that as well. And then this just goes back to the research showing increased hypermobility, increased anxiety. Yeah, the pattern is really clear the more you see it. Again, lack of support, treatment, medical disbelief, or mistreatment due to physical health, all impacts on the general level of exhaustion. Yeah, it's a lot of work to actually, often I think when people get the care they need, it's because they've had to chase and had to work really hard when really it's not, it should never have been your job to do that. And I think by the time a lot of people come to this clinic, there's an exhaustion with healthcare, which is very understandable. And maybe people have given up on talking to medical professionals or a GP because of, yeah, of not being taken seriously enough. So by working to manage both mental and physical health in tandem with energy levels within neurodivergent friendly bounds, the goal is maintaining a more long-term management plan rather than, as I said earlier, focusing on one symptom at a time. Yeah. Does anyone have any questions about that? Yeah, tricky cycle, I suppose, between mental and physical health. Before we go on to energy, are there any free mental health services geared for neurodivergent individuals? In Sussex, I think there's quite a few community opportunities and free sort of organisations in that sense. But I think, again, a lot of them probably have quite a long list, or if they're not free, would be, yeah, private and maybe a bit expensive. There's also, I think, a big push within the well-being service in Brighton and general ATS to take into account neurodivergent adjustments and reasonable adjustments and how to, yeah, screen better, I think, honestly, for some of these complicated conditions that overlap. I think there's still a lot of bias as well there that they're working through in terms of, I think a lot of people we see in the clinic comment on how they've been turned away for being too severe in one service, not severe in another, for example, and how actually I've noticed it's more just about the phrasing of, if someone has neurodivergent adjustments, that can still be done in like the standard sort of therapy process if someone, you know, the practitioner really does understand and is also trauma informed. But in terms of direct links, again, I can have a look at that and email if you're interested in that, because off the top of my head, I'm not too sure. How do you know what exercises are suitable not to irritate conditions focused on? Will this be covered? Yeah, in this session, that won't be, but in the January physical health session, I'm sure they're going to, I say they, that's Bex Simmons, that's nurse consultant, and Beth Sutton, who works in the neuro service. I think they'll discuss that, but also we'll go over this again at the end, but I think we're going to be discussing that in a separate session one day as well, because yeah, it's a big point. Definitely. Okay, I'm having that problem trying to manage EDS. Physical job, my knees are in a sorry state, but I have no idea if I should carry on as usual or rest, and what to do. A lot to think about. Yeah, this is it. And a few of our next slides are going to talk about how hard it is to juggle daily life, managing mental health, managing physical health, and then healthcare appointments and things on top of that. It all takes up a lot, and the more you do of one, the less energy you have for another thing, and everyone just says, oh, you need to rest. So, you know, it's looking rather than, oh, I need to rest, thinking, how often am I resting, and planning for that, and planning for knowing what activities might drain, and physically and mentally, and I guess trying to Tetris it realistically. Okay, so looking at how energy, motivation, and mental health impacts neurodivergence and hypermobility. Firstly, we'll look at executive dysfunction, which, yeah, mostly we speak about this in ADHD, but it's also something that is present in autism as well. So executive dysfunction, it's defined in the box there, but to explain it a bit more, it's, I guess, the pedal in our brain that says go. If deciding and planning is the gears, we get it all ready to get going on a task. When we start it, when we get up and do it, that's executive function. And so that's why often in ADHD you have issues with starting tasks and organization, because you'll know what you need to do, but actually getting it going, sometimes it just struggles to. And of course, this has a big impact on not just the social, occupational, and academic functioning, but it can also impact the way we access healthcare and manage our pain and things. If, for example, you know you need to have a routine appointment, but forget to book it, or find it really hard to get to appointments on time because of things like this, it's just another factor for healthcare providers, and I guess for all of you to have to deal with in terms of, yeah, daily life. And there's a great how ADHD can impact executive function. I really like that illustrator. They do some good infographics on how ADHD can look sometimes. Similarly, overwhelm has an impact on all of this as well. Increased sensory processing or decreased sensory processing can lead to sensory overload, and intensive stimulation can be overwhelming. This could trigger behavioral, physical responses such as increased heart rate, blood pressure, anxiety, and distress. Obviously, this ties into if people have autonomic symptoms or POTS that already impact on heart rate or anxiety and blood pressure. You can see how that can make it harder if you're overwhelmed more frequently than someone else. Raymaker did a good study looking at autistic burnout in ASC, and there's a nice quote at the bottom just sort of explaining how much it does impact living up to the demands that are out of sync with our needs, and this is arguably before you put physical health into the mix, you know. And this shows a little diagram of life stressors, barriers to support, and how this compounds and can snowball into that burnout if there is a lack of support, poor boundaries, gaslighting, that counts medically as well. And I think lack of external resources, support services is something that the NHS in general, everyone's probably really felt that one. And then life stresses, there's a lot here, like masking is a big tax already, expectations, managing disability, and that you can include, say, hypermobility and pain. And then there's just general life changes and stress of like work, transitions, mental health. So yeah, there's a lot of aspects that all culminate, I suppose, to the general stress, and then that impacts on energy and pain. Go back to the thing here. Yeah, it's at the bottom. Those with ADHD generally have a 30 to 40% delay when transitioning from one executive function to the next. Yeah, again, things like physical state changes, again, both for ADHD and autism, it can be really difficult with pain that might suddenly appear and change. And I think it's very common for people in our clinic to take longer than others to access or go seek a diagnosis for something, or get a body scan if needed, for so many reasons. Again, back to being dismissed for years, but also because there's so many steps to planning and traveling. But yes, did anyone have any questions about this energy and motivation section? Yes, part of the next session, in the managing physical health and burnout's a big part of that. I think they're going to break that down and offer some advice in terms of what it means to like conserve your energy well, I suppose, and how you can start to structure that both in a way that's ADHD or autism or ADHD, if you have both, friendly. And for some, it's more of a case of dialing back on the amount of demands in a week and having set times to, say, do exercise as a broad goal, but rather than having a set, I will go to this gym and do this for so long, it's more, I will exercise, and then on that day, if I have high energy or low pain, where would I go, what would I do? And if I'm on a high pain or low energy day, what's the one thing I could manage doing? And I think something that's helped me in motivation and energy management is making that kind of menu for my day or life, in terms of, at my best, what could I get done? Or at my lowest, what could I get done? And just working to that, really. And I think there's a lot of leeway that should as well be given in terms of work, with reasonable adjustments, if that's accessed, and if not, things like access to work or disability rights and support should maybe be followed, even just for reasonable adjustments, like a slightly more flexible time or more reminders, if like forgetting deadlines or appointments is something that comes up at work. These are things that you can ask for under reasonable adjustments. Any other questions? Nice. Okay, further mental health sessions. This bit's to give an idea about some specific things that we want to talk about. So first, a sort of question to all of you. Today we've spoken about the mental health overlap in general between neurodivergence, but would people be interested in specific sessions for anxiety or depression with ASC, ADHD separately? Because they are very big topics that I could talk about for hours, really, in terms of the overlap. And if there's any others in the chat that aren't in the PowerPoint, please do suggest them, and I will make a note to look into, because this is the thing when we're looking at neurodivergence, which impacts the way we experience life, and hypermobility, which changes the way we experience our bodies. It's endless, the amount of links and things you can look at. So there's a lot of potential, I think, for the research that will happen over the years here. And I'm thankful that all of you've been able to be here for the start of it, and hopefully the interventions and research will be interesting to you as well, or helpful. Will we have access to assistance with creating menus and use certain services you mentioned? I think there's not a set plan around this, but I think that would definitely be within like our service provisions one day, when the interoception is set up and put in place, more hands-on kind of resources and sessions like that would, I think that'd be useful. But again, it's still to be planned. So I'll put that down as a priority though, because it's a good idea. ND coaching, no, exactly. ND coaching is a really good example of occupational input and how to work your neurodivergence to suit your life, to suit your career. It's definitely possible.